my presentation is about the use of Miniscrew as bone maintainers. It's a new approach to use Miniscrew to maintain bone in growing childs, in agenesis case or multiple agenesis cases. And sorry. I have a problem. I can't go on. Okay, now that's better. I come from Recanati. It's a little town in the middle of Italy. You are invited to visit us. We have a lot of traditional people, like this is Leopardi, romantic poet, or singers. This is G, important tenor. It was considered the greatest tenor of the past century, and so on. Also Messi, the grandfathers and mother of Messi is from Recanati. They moved to Argentina, but they are originally from Recanati. And my background is from Aarhus. I studied at Aarhus University with Professor Melsen in 19, and you see the group was very, very good. This is Lorenzo Franchi, you know, from the studies of orthopedics together with Professor McNamara. This is Atanasio. He was the president of World Federation of Orthodontists and so on. So it was a very nice group, and Birte Melsen came to Italy because she has a house in Italy, and every summer we meet together. You can see here is Professor Baston, and there was a study group. Every year we carry out the worst cases, and this idea, for example, also mini implant as bone maintenance, is born in this study group. Now, about tooth-agenesis, we know that the prevalence of tooth-agenesis varies according to various populations. And in some populations, lower premolars are the most frequent agenesis, and in the other ones, upper incisor is the most frequent. But now we know from literature that the state of the art in agenesis cases is that we want to close the space, because the long-term follow-up of implants insertion and implants rehabilitations are very poor. Aesthetics, because we have a lot of problems with implants over the years. And you can see here, for example, that the papilla, there isn't the papilla no more here. And we have a bone necrosis and some problems. The problem is that orthodontists continue a lot to open the space very easily. And that's a problem because the literature doesn't accept this trend. And there is a gap between the literature and the orthodontist attitude. So it's important to understand that the future is to close the space, to have better long-term results in our patients. So there are some cases that we are very forced to open the space. For example, if the canine is very big, you have a dimension that is not suitable to the dimension of the incisor, maybe especially in monolateral cases, maybe it's better to open the space for an implant because you can create an asymmetry of the smile. And also in skeletal class 3, you have problems because when you have a flat profile, it's easier to open. But nowadays we have Miniscrews, and by Miniscrews, even if these extreme cases where we have flat profile, we can move forward all the dentition, and we can treat also these cases by closing the space. Obviously, also from a cost-benefit point of view, the underlying malocclusion is important for the decision together with the patient and the parents. So, for example, only an example to show that we can close spaces even in cases very extreme. You see this girl you have a fat profile, and now you have also an asymmetry because you see in the lower arch, you have the canine it's different from one side to another. And if we use a class 2 elastics here, we worsen a lot the asymmetry of the lower arch. So in this case, we can use Miniscrews, closing the space. You can see here, you have a transparent bar that can, we can have a contraction of this bar. You can also design a transparent bar, a unique transparent bar, but the important that you make a contraction because we know that the bone in the premolar area is more little than in molar. So if you want to avoid fenestration, you have to contract your TPA to prevent fenestration of molars. So you have Miniscrew, we close the space. Here's the treatment progress, and here's the finish. And only to show that even in these very, very strange cases, we can close the space. Now, this is the final result. It's almost concave, but it's nice. It's a nice girl, a nice face. This was the initial, and so on. She doesn't improve, but she didn't improve, but it's okay. It's okay. Now, if we decided to open the space, we have some possibility to substitute the upper lateral incisors. We can use removable plates, of course, but they're very uncomfortable. They require a lot of compliance for the patients. They create a desepitalization of the mucosa of the ears. They are not so good. And a little better are adhesive bridges, we know, but adhesive bridges in growing child is a problem because the clinical crown of this patient is very short, because soft tissues haven't matured yet completely. So sometimes we have to perform some invasive procedures, some preparation, some grinding, and this is not good. And the rotation of this adhesive bridge is very limited due to these short little crowns. So we know that there is also another problem because bone resorption in this patient happens very early during the treatment. From the beginning to the end, we have the resorption. And you see, this is a study from Nanda. This is on stone models, but he did only on CBCT, and you can see that you have a difference of until 25% from the beginning to the end of treatment. So 1/4 of your bone is resorbed just finishing the orthodontic treatment. And the concavity, the labial concavity of your agenetic site is sometimes doubled. So you have a problem just at the end of orthodontic. And in this case, obviously, when they at the adult age, these patients will receive bone graft to have a success in the implant insertion in 68% of cases, very, very, very much. Now, can we prevent this bone resorption? Yes, we know from bone biology that if we give a stimulum to a mechanical stimulum, mechanical load to the bone doesn't resorb. We know from implant, we know this. So you can see from this micro CT, for example, that around the implant, you have a bone, a density bone very similar to the bone density around the natural teeth. And also there are in literature some examples like this. They insert a Miniscrew from one side, the other side was a control, and they studied the bone density around the Miniscrew. You can see that only after 3 months you have an increased bone density around the Miniscrew. So these results are very are very promising for our aim. And the first who thought to use Miniscrew as bone maintenance was Dr. Graham, and in 2007, you can see that he used a Miniscrew inserted vertically in this patient, and he cemented a pontic on the Miniscrew, and so on. But also there are some variation of the technique. More or less are all the same. This is paquette. You can see some variation how you build the pontic, but the technique, the idea, the rationale is the same. And they say, Graham say that the osseointegration isn't complete using by Miniscrew. And this is true, but we know that it is very much because the osseointegration. If we define the bone to implant contact as osseointegration, we know from several animal experiments that is from 60 to 8%. So it isn't complete, but it's very huge. And this is important because when you insert a Miniscrew, you have a sort of osseointegration of this Miniscrew, and that's why Kokic warned of the problem, and he suggested not to use vertical screw in the edentulous areas of a genetic patient, because the possibility of vertical angular defects, it's easy. And Kokic from 2011 suggested not to use in a vertical way this Miniscrew. And you can see from this case in Orus department that they leave this Miniscrew for maintainer, and the molar, just after 1 year, has lost its contact with the upper molar because the vertical growth is prevented. The Miniscrew is like an ankylosis tooth. You don't have vertical growth. You can see here from this clinical example. And another paper, this is another group. They have a boy that lost his upper lateral incisors, and you can see they insert a Miniscrew and they built a pontic, and you can see that over the years you have an infraoclusion. You see that here the mesial papilla doesn't exist anymore, because during the insertion is not centered, it's little mesially. You have destroyed one papilla, and the bone can't grow anymore in that site. Here's another article. This is Scope, and there are 2 case reports. And you can see that when you have, in the first case, this one, when you have a lot of space, you can use a vertical screw because you have a lot of space and the bone can grow around the Miniscrew. But it's rare. We know that it's very difficult when we open the space to have so much space. Generally, it's little, and it's very difficult to open properly the space. Like in the second case, you can see here, and he knows that if he would have used a normal Miniscrew, he would have a problem. So you can see that he used a very thin Miniscrew to prevent, to let the bone grows, a very little Miniscrew. But a very little Miniscrew is a problem for fracture because they are very prone to fracture. Another paper, this is Wilms. They say that they have observed this phenomenon of infraocclusion of the Miniscrew in this patient, even if rarely. Okay, rarely it's okay, but I think that if we use a technique that you never have an infraocclusion, is better than a case when you have an infraocclusion, even if rare. And also him suggests to use a Miniscrew small enough to avoid interference with alveolar growth for the problem we have seen before. But the problem of this patient is the width. You can see from this case, for example, that the 8 is not a problem because these children are growing children. So you have a vertical growth, but the problem is the width. You can see here. If we insert a 1.6 millimeter diameter Miniscrew, for example, you cannot prevent the bone resorption. The width of the bone resorption can't be maintained because the diameter is very little. That's the big problem with the vertical insertion. And for example, here you can see that no problem with the vertical growth, but with the width, yes, because you haven't anything to maintain the width of the alveolar process. And if we see also literature, you can see that the width is proud. This is a review article, the review article from Eastman, London. And you can see that when you perform alveolar ridge preservation technique, if you see at the value of the 8, you can see positive values. The maintaining of the bone is very, very good. But if you see the width, you see that you have only negative values, even with this technique. So it means that it's very difficult to maintain the width. And Ludwig also doesn't suggest to use vertical insertion because he thinks he had some cases of fracture. And we know from literature that when the Miniscrew is minus 1.6 millimeters diameter, the probability of the fractures is very high. If is more than 1.6 millimeter, it's possible, but not so frequent. But we know that if you use a very thin Miniscrew, the fracture can happen, and that's why it's suggested not to use. You use a cantilever technique with the palatal Miniscrew, different from my technique, but not vertical insertion. And now that's we have another problem, because if we insert a vertical Miniscrew, we have to accept that some percentage of Miniscrews have a failure. And when we have a failure with a Miniscrew inserted in the dental areas with a very thin cortical plate, you have a failure, it's a disaster. You have destroyed a lot of bone of the dental area. But it can happen because clinically you see the patients that the screw is okay, but if you take an X-ray, you can have a bone necrosis and inflammation. And this is another example from literature. You can see in this case that in the case you have an infraocclusion of the adjacent teeth, and this Miniscrew has been lost over the years. Okay, buccolingual thickness is our problem. We have spoken about this. That's why the idea to insert an horizontal Miniscrew, because inserting an horizontal Miniscrew in a bicortical way, you can maintain the width of your dental area in a very easy way. And the idea was born in a casual way. They forgot this Miniscrew in the department. They forgot to take out the Miniscrew. And after 1 year, they see that the bone was maintained. So on the right side, you can see the bone is maintained. On the left, you have a very bad resorption. But it was a case, it was a fortunate case, to a lucky case. And after that, they began to study in the dog, to study what happens really in a more scientific way. And you can see in dogs that they started to fit one side, on both sides, and on one side they inserted Miniscrew, and on the other side, the control group, no Miniscrew. And you can see that where you insert Miniscrew, the quantity and the density of a bone is more than the contralateral side. And here is another example. You can see that the bone density is very good. You can see here. So I began to a clinical study with my patient. It's a clinical series, and what I have done, I take 5 patients that received 6 Miniscrew as a temporary pontic after orthodontic treatment, and they were followed over the years, over 5 years, with intraoral images and radiographic images. These records were taken at 2, 3 years, and 5 years follow-up. Now you can see the technique. This is an Aurus Miniscrew. It is inserted in the palatal side at the level of the coronal third of the root of the adjacent teeth, and here's the wire. I construct a wire, sectional wire in stainless steel, 21 by 25. It must be very rigid, and you have to make a 90 degrees like you see here. This is mandatory, because when you have this degree and the patient, you have pressure during occlusion, it's okay, because you have like a torque in the slot, and the tooth remains stable. Okay, it's mandatory to have this configuration of the wire, not straight, but this one. Then you can apply your primer, your bonding agent. You can build it directly in the mouth, or if you don't want to do this, you can, the technician can build up a crown, a temporary crown, and you can adjust this crown in the mouth. There is no problem. It's what you prefer. There is no problem. And here is the case where the crown is adjusted in the mouth. And then you can refine, you can polish with the silicone points, with the diamond bars, and so on. The surface must be very smooth, near gingiva, and then you ligate your tooth in the patient at the end of the treatment. You can see here that the ligation with this kind of Miniscrew is a little complicated, and now I use another screw that have a bag head, because this technique of ligation is not so easy in the patient. But if you use, for example, this Miniscrew, they have a bag head, like a bag bracket. It's very easy to tie sectional on this Miniscrew. Then you can apply a flowable composite for comfort of the patient, obviously. And this is resolved. You can see that inflammation around the pontic, there isn't. Inflammation around Miniscrew sometimes, but the patient brush more and can use daily chlorhexidine mat rinsings and so on. There is no problem. But it's very interesting that you have no bone resorption around Miniscrew, because in the palate, the cortical plate is very, very, very thick, and the percent of success in the palate when you insert a Miniscrew is 100%. So no bone resorption around Miniscrew, because the cortical plate is very thick. Sometimes we have the ligature breakage, but because it was at the beginning, I haven't done the 90-degree bend. If you keep the wire straight, you have a mechanical load very, very high, and you can have the breakage of the ligature. But nowadays, with the 90 degrees, no problem. Gingival impingement can happen because this patient grow so vertical. Some patients grow a little, some patients grow more. It depends, and you have to see if there is a very large vertical growth. You have to adjust your wire according to the vertical dimension of the patient. A discoloration of the pontic can happen, but it is very easy to correct because they are composites and there is no problem. Now let's see some cases. This is a case. You can see also there is a transposition between the canine, the premolar on the first quadrant. And you can see at the hand, I inserted the miniscrew and the pontic. It's a bilateral case. Insertion of the miniscrews. At 2 years control, and now at 3 years, you can see that at 5 years, you can see you have an overgrowth of the mucosa. This is not so frequent. It can happen in limited case, but you can adjust the wire. There is no problem. You can see that the cortical plate here. You can see how the cortical plates is okay because there isn't a miniscrew that perforate periosteum or bone. It's completely free. So you have a physiological and natural growth in that site. And there is a correction also of the transposition. And this is the panoramic X-ray, follow-up panoramic X-ray. Now another case. This is a monolateral case. You can see here. You can see the 90 degrees bend of the wire, insertion of the miniscrew, follow up at 2 years, and at 3 years, obviously you have to splint adjacent teeth to prevent relapse of the root inclination and so on, and ears at 5 years, no problem. Panoramic X-ray, and so on. So this technique, in this case, serious that there are only 5 patients, but it's very good. There are promising results, but you can see that if you want to read the article, it's also in the American Board reading list. It's free. You can go to the site of American Board and you can download the article very free. And also this is free. It's a case report, mouth and teeth. You can see mouth and teeth, Ciarlantini. You can download the case and so on. Now, let's point out some mistakes because the technique works well if you do in a very detailed way. Because if you miss something, some passage, maybe you can have problems. So I want you to understand well the details. So the most common problem is that the screw, some colleagues put the screw far from the top of the alveolar process. That's very bad. You have to put near as possible to the top so that the wire remain rigid. The screw and the wire must be a rigid body. If you put the screw, for example, 1 centimeter or more higher, the wire become flexible and you have a problem. Okay. And remind of the 19 degrees, that's mandatory. We have explained about that. The ligature must be, I will show some example. You need a 2 points ligature to have a stability of the pontic. And you have to monitor, to check the pressure of the pontic on the mucosa. Here's an example. You can see here that there isn't the band here, and this is not good because when you have occlusal pressure here, you can break the ligature. And another mistake here, you can see that the band is okay, but you have 1-point ligature. No, you need 2-point ligature because the wire has to be blocked. Has to be blocked in the Miniscrew. Some of these cases received a bilateral insertion. You can see here at 5 years that the bone width is maintained. So when we have noticed this, in the new cases, we tried to make always, in each case, always a bicortical insertion. That's the aim of the new cases. And also the insertion is possible because it's important because the tip of the Miniscrew must be as occlusal as possible because that's the area more sensitive to resorption, more important for aesthetic reason. And that's very interesting because now I use a surgical guide. I use a surgical guide with the computer. You can, on the computer, incline the Miniscrew. You can choose the dimension and so on before going to the patient. And that's very easy. You can see, the patient wears this. This is a transfer to calculate the error, the dimension error. And you have also soft tissues on the computer and so on. And you can control very well the insertion. And this is my surgical guide. You can see you have some holes here because when you insert in the mouth, in the patient, you have to be sure that the surgical guide is correctly inserted. It's not insertedly non-corrected. So is this important? And I also ask the technician to make this space because I want to see that the plate is very parallel to the mucosa when insert for hygiene, for a better hygiene. So I have double control. I want to see with my eyes also if I have a surgical Miniscrew. And this is a recent article on the technique. It's a review article. This is from Eastman Institute in Rochester. And they ask, but are useful this Miniscrew? The question was, are they really useful to use? It's really useful to use this Miniscrew for bone resorption. There is an evidence of this. And they choose 6 after I've seen 125 articles, and my article was inside inside the list of the article chosen, and the conclusion was that there is a limited evidence that we can use this pontic. That's important. That's important because it seems that the way is right, but they added also a sentence, very important, that three-dimensional imaging are very important to do in evaluating bone levels. Because if we show a two-dimensional image, we don't know really what happened in our patient. But if I take an initial combine and the final combine, I really see what happened in my patients. So the recent cases, we decided to do a multiple center study with the University of Marseille and Montpellier. They like the technique, and so we decided to make a study together. And we have 18 patients, 26 hygienic sites. And CBCT were taken at the beginning and after 2 years. And that's very interesting what we have seen here, for example, is a clinical example of the case. You can see that it's a bilateral case. And here are the pontic inserted in the patient. And now look at this. You can see that you remind on the article that we have a resorption just at the end. And you can see here, this is an example. You have resorption just at the end of orthodontic treatment. And at 2 years, you can see that soft tissue is good. And this is at the 4.5 years. And you can see that the soft tissue, you have an overgrowth of soft tissue. It's very nice clinically to see this after so much time. Here is the beginning. And if we go to the CBCT, you can see that the cortical parade is thicker, and that's good for implant insertion. And here's the other side, and okay, the same result. So other cases, other example, initial, final, you can see that also the morphology of the alveolar process is maintained in these patients. And you can see this case. When you have this perforation, if the periosteum remain not perforated, it's okay. You haven't a problem. But obviously, it's better not to do. Here's another case. Even with cases, these cases where the width is very thin, you can see that is maintained. It's maintained. You can see that the bone density is more than the beginning. You can see here. And then all these cases were measured according to a method. This is the Nanda method. The method means that you have to orientate to put the CBCT in a standardized way to measure really in the same way each patient. And you can change inclination of the miniscrew, but the angulation remains the same in all the patients. That's the method that Nanda used in his article. You can see the values. Bone width in this case, for example, is the yellow one is to do after 2 years. You can see that it's okay. The bone width is well maintained. And the labial concavity and the bone height are also good. Another side, you can see that the values are very, very good. They are measured at 2 millimeters, 4 millimeters, 6 millimeters, 8 millimeters, 10 millimeters from the top of the alveolar process. You have more measures meant. And this is labial concavity and the bone height. Obviously, we have to perform a statistical analysis of this result to understand if the difference is statistically significant or not. But that's only a temporary result. It's not evidence-based still, but it's very nice to see that in all the patients treated until now, because the study isn't finished, we have to treat more patients to conclude. But for now, for the patient that we had, you can see that the bone width and the labial concavity in an overall value is more or less the same. And I'm very happy of this conclusion, because maybe we can reach an evidence-based result that's important if we want to study something in orthodontics or in dentistry. Now, the technique is very useful in lower premolar agenesis and in multiple agenesis cases. I will show you now, because the horizontal section can maintain the width of the process. This is a girl, you can see a skeletal class 2, a huge class 2, mandibular retrusion. You can see the overjet very huge. And this is the Ceph. Now, in these multiple agenesis cases, the aim is try to close the spaces to limit implant insertion. So, in a cases like this, if we can insert only 2 implants, it's a very, very important. So, here we have a baby canine ear, baby canine ear. They take out, and the treatment plan was to mesialize the permanent canine, to mesialize also the molars, so that at the end, what happens here, we extracted these baby teeth, and the implant insertion was limited to only 2 implants. Now let's see some clinical pics. You can see after extraction, the patient, mesialization of the canines, and insertion of the miniscrew. And if you see the CBCT of this case, you can see that the vertical growth has happened in a very natural physiologic way without problems, and the width is maintained. This is on one side, and this is on the other side. You can see how the alveolar process is maintained about the width and the height, because the growth is happens in a physiologic way, because the screw is gingivally to the periosteum. So the growth is a natural growth, without miniscrew. So in multiple agenesis cases, it's very useful to have this miniscrew to maintain the width of premolar. This is another case. You can see that in this case we want to move the implant insertion as posterior as possible, because it's better to have implants more posteriorly than anteriorly. In some cases, they want to close with canine and then put the implants posteriorly, because it's easier. It's more predictable. And now I can show you a lower incisor case. You can see this patient with, you have an agenesis of a lower incisors. This case is published on JCO, so if you want to go to read. And this is the CBCT. You see that the cortical plate, this is the lingual plate, and this is the cortical. You see the cortical plate is very, very thin. So what we did, we inserted in this way. I don't use the pontic. I inserted a surgical screw, opening a flap and then close, because here the cortical plate was very thin, and I think that it was not suitable to receive the load so much. So we inserted the screw, and we use a Maryland. It can be a very great technique to use the miniscrew together with the Maryland. There's no problem, because the miniscrew can preserve bone at the same way, together with the Maryland bridge. And you can see that only after 2 years, the bone density around the screw, you can see here, the bone density is good, is more than the beginning. And if we see the CBCT, you can see that the thickness of the cortical plate is good, it's very good. And if we do a 3D reconstruction, you can see that here there is a cortical plate, but we know from literature that in CBCT sometimes when the bone is very thin, the machine doesn't read the presence of the bone. So here we have a very thin cortical plate. And now you can see that the cortical plate is thicker. And that's very a good image and a promising result for the technique. Now, this is a transfer case. This is transfer case. I inserted today this case because you can see this girl has treated for 5 years. You can see that how resorption we have, and there was a problem here because we have resorption, we have bone loss, and this is a very, it's a disaster like a case. So this girl has lost 2 teeth, and this is the lateral X-ray. And what happened is this is a very nice girl. It's a normal class 1 skeletally, but you can see when he lives, she has a lot of problems, you can see here. And when we see inside, that's a very problem here, because now the patient received the bone graft because she went to surgery. She went to surgery to reconstruct because after the loss of the teeth, there was a bone deficiency, very bad. So she went into surgery. She received the reconstruction of the alveolar process. Now, the problem is that we have a deep bite here to correct this curvus P. But we have to maintain this over the year because she is 16 years old. So our aim is to postpone the implant insertion as late as possible. Because we know from literature, from a study, for example, by Birgit Tillander, that if you make an implant at this age, you have a sure infraoclusion. And that's a disaster for a young girl like this, to have one side a level gingival and the other side infraoclusion, a disaster. So you can see that the surgeon was very good, very clever. And now we have our aim is to maintain this bone for to carry the patient at adult age with a very aesthetic alveolar process. So, conclusion. Vertical insertion, I have some problems in my opinion, because to obtain the adequate space for insertion is rare. To have the correct inclination during insertion is difficult, because if you make a mistake, you can destroy one papilla on mesially or distally. If you are forced to use a very thin miniscrew, a fracture can be possible easily. And even if there is a miniscrew failure, is a problem. So there are a lot of complications that I think that it's better to go to a more simple technique. And even if in premolar agenesis, vertical insertion is of no utility, because the diameter is very thin, so we cannot use in premolar agenesis. So I prefer an horizontal insertion in this patient. Thank you very much for your attention.